Good morning and welcome to the second session on day 2 of the Division of Mental Health and Addiction INARMS Symposium. Day 2, session 2 is sponsored by Mental Health America of Indiana, Indiana Association of Peer Recovery Support Services, and Project ECHO with Indiana University. Mental Health America of Indiana is Indiana's leading mental health and substance use advocacy organization. Mental Health America of Indiana is dedicated to providing overall mental wellness and recovery for all Hoosiers. Thank you, Mental Health America of Indiana, for being a partner in change. Indiana Association of Peer Recovery Support Services is a professional association dedicated to advancing the peer recovery support profession through support, advocacy, and education. Indiana Association of Peer Recovery Support Services, thank you for being a partner in change. Project ECHO of Indiana University. Project ECHO is a no-cost to participants program offering primary care providers in Indiana an opportunity to collaborate with IU School of Medicine specialists to improve Indiana health while becoming a local expert in opiate use disorders in their region. Project ECHO of Indiana University, thank you for being a partner in change. We thank our partners in change in coming together to celebrate September's Recovery Month at the INARMS Symposium. Back to you, Blake.
Thank you, Sunny. Thank you, everybody, for joining this today's presentation. We're pleased you could join us this morning and appreciate your participation. This session has 2 parts. Best Practice in Treatment Part 1, Dove House Model, which will be presented by Wendy Noe, and Best Practice in Recovery Part 2, the Oxford House Model, an evidence-based recovery housing model that will be presented by Amy Collins. Our presenter for Part 1, Wendy Noe, is Executive Director of Dove House Recovery for Women, the largest transitional housing organization in Marion County for women recovering from addiction. Wendy is responsible for overseeing all operations and growth for the organization, including fundraising, program development, staff supervision, advocacy, communications, and marketing. She has been advocating for women her entire life with the Julian Center, Domestic Violence Network of Indianapolis, Susan J. Komen for the Cure, and now as the leader of Dove Recovery House for Women. Dove House is home to 40 women each night and has experienced a 60% capacity increase under her leadership. Wendy has been awarded the 2006 Indiana Coalition Against Domestic Violence Empowerment Award through education, the 2012 Indiana Cancer Consortium Controlled Champion Award, and the 2017 University of Indianapolis Community Partner Award. In 2019, Dove House received the Recovery Residents of the Year Award from Mental Health America, Indiana. Wendy, we'll turn the floor over to you, and we're looking forward to your presentation.
Thank you so much. I'm excited to be here and to talk briefly about the Dove Recovery House model, our experiences and what we've gone through in the last 6 years, and hopefully enable you to develop a model that makes sense for your community. So today I'll be talking about how to develop a best practice treatment and program and why collaboration is key. I won't go through my bio too much because we have a short amount of time, but I've had 20 years of leadership in nonprofit management. I've testified on several bills, and I've raised the Dove House profile and budget from $250,000 to a budget of just over $600,000. So my goal today is to help you understand the importance of, sorry, I just lost my screen. Understand the importance of prioritizing staff training and competency, brainstorming the ways to develop the program to be a best practice program for women with SUD and learn from the growth challenges of Dove House, to understand common residential SUD policies and procedures and the importance of having them written down and understanding them, and including one for MAT. Developing understanding of the program's needed steps to expand your program fiscally and programmatically, and learn the importance of being collaborative to have a successful program, and how to identify key partnerships, as well as identifying indicators of success and consider implementing measurement tools to track outcome data. So why Dove House? Dove House has gone through quite the transformation over the last few years. When I started, Dove House was really known as just a halfway house, that typical kind of small halfway house, some programming. But today we are considered a recovery resident, and we have been recognized by the governor's office as the best practice model that they would like to replicate throughout the state of Indiana when it comes to women with SUD. When I began, we did not accept MAT. MAT was frowned upon, it was looked away from, it was not supported. Today, we accept women on all forms of MAT. We understand MAT is a best practice model and as an addition to a woman's treatment here at Dove House. We went from a staff of 6 to, actually this stat is a little bit old, we have a staff of 15 now. We primarily only had life skills programming for our clients outside of 12-step meetings. Now we are trauma focused. So at the core of everything that we do here at Dove House is trauma focused. We had no therapy. Therapy was not a requirement of our program. We actually were not even enrolling individuals on health insurance. Now, one of the primary things when they first come in is that we enroll them on health insurance and that they are assigned a therapist. We have our own therapist on staff, and then I have a contract partner who is here part-time. So we have 1.5 therapists. All of our clients are expected to participate in 1 hour of therapy at minimum every week. We went from a 62% success rate, and that success was defined as a minimum stay of 90 days. So not a lot of parameters around success. Today, our success rate is 73%. And success is defined as a minimum stay of 90 days, and then upon completion of our program, they transition out into their own home, reunited with healthy family members or friends. They are living independently. They are substance-free and have had no relapses. They are working or they enrolled in school. Essentially, they are contributing members of society. We had no clinical staff. Today, we have clinical staff. We have a director of clinical services. We have licensed staff. We have peer recovery case managers. And as I mentioned, we have a licensed therapist. It is a requirement as a part of the Dove House model now. We had no policies and procedures. Nothing was being written down. Everything that we were doing was pretty much based on paper, and 75% of all of our funds were coming in the form of grants. And if you are working for a nonprofit, you know that is not a healthy model. If you have 75% of your grants, if one of those grants goes away, your budget is significantly hurting. Today, we are an evidence-based practice. As I mentioned, the governor's office is recognized as the best practice model, and we have a distribution of funding that is equal among several branches. So we have Medicaid funding now, Recovery Works, grants, individual donations, corporate sponsorships, and fundraising. And we are an evolving staff culture to a professional and prepared staff. We are no longer reactive and putting out fires every day. So staff competence is one of the big things that we've really worked on. Again, we're no longer a reactive staffing model. We want to start it off right. And we do this through thorough new hire training. Everyone is immediately assigned a supervisor who we provide close monitoring and support. And we have developed orientation and competency checklists. What are they? Why are they important? We want to make sure that we provide samples so that everyone knows exactly what their responsibilities are. So you can see here that we have an onboarding orientation and checklist. Everything from what's their email, their password. We update our website so everyone has headshots now, keys, and then we do background checks, criminal background checks. Everyone is drug screened here. We set up tasks. What do we want them to accomplish in their first 30, 60, 90 days while they're here? We review rules, policies, and procedures. Everyone is given an employee handbook. We have a confidentiality form that everyone signs. And every new staff member is also introduced to our board of directors at one of their first board meetings. This is just another example of our clinical competency checklist. Again, we want every staff member to understand immediately what their roles or responsibilities are so that they can't come back to us later and be like, I didn't know how to do that. Nobody ever taught me. Everyone has a very key role here at Dove House now. And while we work together collaboratively, we all have our distinct responsibilities. We do have an open door policy, so we want to make sure that everyone knows that they can come to their immediate supervisor as needed. We know that things are going to come up, especially working in a residential setting like we have, but we want to empower them that while they can come to their supervisor at any time, we want them to make those decisions, those immediate necessary decisions. We will provide immediate and continuous feedback and informed care. We do have weekly supervision. Our clinical staff meet weekly individually, and then as a group, we do a weekly whiteboard meeting where we do a clinical oversight. We do twice a week, we do a huddle, a staff huddle, just as a check-in. What's happening? How's everyone's emotional well-being? Are there any immediate things that we need to solve or find a solution to? Monthly, we have a staff meeting adjusting clinical and operational needs. This is mandatory for our entire team of 15. Quarterly, we have clinical and operation trainings based on needs identified by staff and leadership. And then annually, we have refresher trainings in ethics, cultural competency, trauma-informed care, and other clinical and operational needs. Annually, we have everyone sign their job description as a renewed commitment to the organization, and we do provide annual performance reviews. Our clinical director provides a supervision with the entire group. I also call that a whiteboard meeting. So we talk about any clients that are at risk, if there's any needs from the team, any updates, if we have any discharges that happened or that are coming up, and if we have any new admits. And again, this is a great way for all of us to always be on the same page. So as you're developing your program, the questions that I would ask is, what are you willing to do? And what are you capable of doing? You need to prioritize the needs within your community. So perhaps you have a lot of, for example, residential programs for men, but not as many residential programs for women. Perhaps that's your priority. Who are your community partners? Can you maintain stability while being flexible as things evolve? That's the one thing that we've seen here at Dove House is we're constantly evolving and growing and maturing as new evidence and information comes out on how to treat SUD. And we need to be flexible around that. Another great example is COVID-19. We immediately went to a telehealth model within 3 days back in March. Our staff was prepared. We were ready to do whatever was necessary to ensure that our clients were well taken care of. And then make sure you utilize your Indiana support networks, the Department of Mental Health and Addiction if you wish to become in network with Medicaid, and then becoming certified with the Indiana Affiliation of Recovery Residences. This is critical and important. It's the governing body for the state of Indiana in terms of policies and procedures and how we are serving our clients in the community that need us. This is to ensure that the clients are receiving the absolute best care that they deserve. INAR has several levels, level 1, 2, 3, and then Dove House is a level 4 because we are a service provider with clinical on-site. I did put the link on here if you want to learn more about INAR and the policies and standards. So you need to prioritize your program development. And the reason you need to do this is that you need to ensure the highest quality care. These are individuals, again, that deserve this. By prioritizing program development, you can evolve the needs with SUD. You may need to add things to your program that you're currently missing. Maybe there's groups that you need to have. We just added a grief program into our matrix because we understood that there have been quite a few relapses and overdoses during COVID-19. Many of our individuals and our women in our program have experienced this grief. And so we wanted to make sure that we were meeting their needs. So we added a grief therapy group that is led by our therapist here. By prioritizing your program development, you're also maintaining compliance with internal and external standards, and you're managing your liability. You do this by making a commitment to best practice. Again, putting your own personal beliefs and standards out of the way and looking at the needs of the organization and the individuals in which you serve, ensuring that you're always meeting the needs and evolving with new evidence that comes out. It's critical to have board involvement and subcommittees on a board level with staff engagement within those committees. Action items need to be regularly tracked, they need to be written down, and they need to be visited often. And then you need to have policies and procedures. If you do not currently have policies and procedures, then you're not really prioritizing your program and your development of that program. This is just an example of our admission criteria. It's our policy. Here at Dove House, they have to be female, at least 18 years of old. They have to have a history of unmanageable disease and excessive use of alcohol and other drugs. And this disease has impacted their daily living skills, their interpersonal functioning, psychological functioning, and their inability to live without the use of chemicals. They need adequate support systems to foster recovery. They have no presenting medical or unstable psychiatric conditions that would preclude them from treatment, no presenting physical conditions that would preclude her from treatment, and no indication they are in need for a more intensive level of treatment like detox. We do an intake assessment with every client that comes in. We track their information, their demographics, psychosocial history, emotional behavioral functioning, alcohol and drug use, their medical conditions. If they have any co-occurring disorders, legal history, their education, employment history, military history. We also do a PHQ-9 and an ACE. So the Adverse Childhood Experience Assessment and a Depression Assessment. Again, this is to ensure that we're meeting and helping a client in all necessities of her life, not just substance use disorder. Again, the focus of Dove House is trauma, and if we don't identify what any early childhood traumas that she had, we're really truly not going to be able to help her the best that she needs. We have a treatment plan that is set forth when every client comes into our program. They work with their peer case manager on this individualized treatment plan. Our motto is we don't expect them to meet us where we are, rather we meet them where they are. These individuals come up with their goals alongside their peer case manager, and they are reviewed every 60 days. And it's to look at what problems do they want to address, what goals with measurable criteria do they have. Therapeutic activities and their frequency. So what groups are they going to? What individual therapy sessions or group therapy sessions are they attending? Are they going to 12-step meetings? Are they working with a sponsor? We track any referrals that we need that we are not able to provide here at Dove House. And then who's responsible for working with that client on that goal? Is it the therapist? Is it peer case manager? Is it the director of operations who leads IOP? And then the resident signs off on all of this and works with, again, their peer case manager one-on-one. Every client is provided a resident rights, so they know exactly what they are entitled to, and then the staff all receive a copy of it. This is our policy for MAT. We do accept individuals on MAT, including buprenorphine, Vivitrol, and methadone, but we do not provide transportation to procure methadone. And if any programming is requested by the MAT provider that may limit the ability for the client to participate in our program, we may not accept them. So we're going to work very closely with that client. We do monitor all MAT. Every medication that we have here at Dove House for each client is locked up behind 2 locked doors. Each client has their own med box that contains all of their medication. We observe and re-record in our electronic medical system. Again, we observe every client who self-administers their medication. We chart what time they take the medication. We count all controlled medications, including MAT, and we log it in our medical record. And then we initial for all observed medications. We also record any med errors that may occur. You know, our job here is to help our clients manage their lives. And so we really want them to understand the importance of taking medication at the appropriate times and taking it as it's directed. We do terminate at times, but we want to make sure that clients clearly understand why we may terminate. And so we have a policy on that. If a client uses alcohol or drug on the premises at any time, they may be terminated. If they bring alcohol or illegal substances on the Dove House premises and sell that, if they give a prescription drug or another drug to another resident, if they're violent toward a resident or staff, if they steal from a client or a staff member, any sexual or intimate relationship with any kind with another resident, disregard for taking or for safety standards, and then taking any nude photos or videos. We do have a consequence for negative behavior, and depending on the rule infraction, they may be written up, and the client does review that with their peer case manager and sign off. And so we lay that out very clearly for every client. We do not discharge from our program due to relapse. We know that that is part of a recovering person's experience, but we will work with them on what led them to that relapse and how we can best serve them. So the Dove House program, as I've mentioned, the major pillar of our program is a belief that trauma lives in the foundation of substance use disorder, and that ultimately trauma is the gateway drug. Addiction is a person's attempt to regulate their own nervous system. And so this is really how Dove House has evolved in the last 6 years, understanding that trauma is the gateway drug. Something came before a person decided to use substances. Trauma-informed care is an organizational structure and treatment framework that involves understanding, recognizing, and responding to the effects of all types of trauma. It emphasizes on physical, psychological, and emotional safety for both consumers and providers, and it helps our survivors rebuild a sense of control and empowerment. Ultimately, that's our goal, that our clients, our women that come through our program, are able to manage their lives and feel empowered to make healthy lifestyle choices. The other thing that makes Dove House is that we're free. We're one of the very few programs in the state of Indiana that's free. And we do this intentionally. We want to ensure that an individual has the time that she needs to get healthy and take advantage of all the programming that we offer. We don't want her to rush and get a job because then that becomes her primary focus. We also want to minimize external distraction. We want to prioritize evidence-based practice in all the services that we provide. We're peer recovery oriented, and we treat the whole person, not just her disease. We use the multi-dimensions of individual wellness, for example, motherhood versus just focusing on you. And then we prioritize staff competence. We provide those one-on-one sessions with their clinical supervisor. We provide professional development skills. We want to see this as an ongoing need, and we want them to be a high-performing team. This is just a brief view of our organizational chart. While we have an organizational chart, we really don't focus on hierarchy. We focus on a high-performing team, and understanding collaboration is critical. We focus on community and democracy, and we focus on a true step down. So we go from a sitting still period for the first 30 days to ultimately living independently. For example, once she reaches a certain level here at Dove House, we can focus on half of the week her living here at Dove House and half of the week living with her spouse. We also have a STEP Success program where we provide outpatient programming to residents who have successfully completed our program. So this is after usually a minimum stay of 6 months here at our program. They've successfully completed our program and they can move into a residential setting of their choice. And then we will provide rental assistance for up to 8 months. So for the first 4 months, up to 50% with a certain cap limit. And then for the next 4 months, up to 25% with a certain cap. And along with that, they continue to meet with a peer recovery case manager, participate in random urine screens, and then participate in ongoing group therapy. The women can stay as long as they need to stay here at Dove House. Average length of stay is about 6 to 7 months, but they can stay here for up to 2 years. The other unique thing about Dove House is that we're home. It may be temporary housing, but it's home forever. Once a Dove, always a Dove. We welcome our alums to come back. We have an alumni-led group here. We encourage our alums to come back and sponsor when they're ready, and to provide key friendship and collaboration to current residents. We do everything that we can to create a safe environment so that residents stay in treatment long enough for it to catch on. Evidence shows that the longer a person's in treatment, the more likely they are to maintain sobriety. We collaborate with key community partners so that treatment is continuous and connected. We have staff that are knowledgeable enough to refer for detox treatment when needed. And then our clients get tested. We have our clients tested for HIV/AIDS, Hep B and C, tuberculosis, and other infectious diseases. In doing so, we can assist in the follow-up following the diagnosis and/or give the resident the information they need to reduce the risk of these illnesses. Many of our clients are Hep C positive due to IV drug use, and so we really want to help them manage their illnesses so that they can live long, healthy lives free from addiction and illnesses. As I've mentioned, that while they're here at DovHouse, their medications are monitored to ensure that the client feels comfortable and competent administering the medication as it's prescribed when she leaves DovHouse. In DovHouse, we do all of our own drug screens. We will send out for confirmation testing if need be. But again, the ribbon that runs through it all is that we are trauma informed. The reality of the program is that we could not do what we do without our collaboration. Collaboration is critical, not just for us and our success, but our clients and the community partners. So the way this works here at DovHouse is that we will receive a referral, usually from one of our collaborating partners, whether it's a treatment facility, a criminal justice provider, or a healthcare industry institution. We also receive self-referrals from individuals, and they may be coming from other treatment programs where they've lived for a period of time and they're either transitioning out or they need more stability than what that current program is offering. Once they've come to us and we've done a comprehensive assessment on them, we will determine whether or not they need detox. We do not do detox here at DovHouse because we don't have medical staff. So we'll send them away for detox. Once they're completed with detox, then they will come to Dove Recovery House. They will come through the recovery residence. They will receive all treatment here at DovHouse, and then from DovHouse, they will move into independent living. The continuum of care is critically important. It helps those individuals who have had chronic relapses, who are homeless, who have experienced trauma, who are uninsured, who have interacted with the criminal justice, and who are unemployed. That warm handoff from each institution and partner is really important to ensure that we don't lose someone while waiting for a bed here at DovHouse. We have some very important partnerships, again, that meet that continuum of care, and that's really critical because, again, we're not losing people, they're not falling through the cracks, and they're receiving the level of care that they really need. Some of our core partnerships include the Marion County Drug Treatment Court, Hancock County Probation Department, Marion County's DCS, the Rubin Engagement Center, and then I have two others on here that I failed to put, and that's IU Health and the Vermilion County Probation Department. All of these entities are guaranteed a certain amount of beds. So when one bed opens up, they know they have someone that they can directly refer into that program. This has been a critically successful component of our program, again, ensuring that these clients don't have a gap in their continuum of care. So they go to detox after they receive a referral from a collaborator or they self-refer. We may have an assessment, and that's what happens for individuals that self-refer. When we have a direct partnership, if they have a bed available, then there's a reduced amount of wait time. Again, as I've mentioned, average length of stay is 6 months, and then they can go into our STEP Success program. I can't stress enough these key partnerships. I wish I could give more beds to these collaborators. We provide weekly or monthly reports. We have seen a significantly lower reduction in relapse. We've had nearly a zero recidivism rates, and it's all due to these levels of accountability and key community partnerships. When we had individuals, we had 18 that entered into our STEP Success program with a success rate of 95%. So talking a little bit about how to make sure your program is successful is by developing a strategic plan. This engages your board, your staff, and your community collaborators. It sets the theme for the next 3 years and understands what the need is within your community. It helps align your staff and board on the priority of the organization, and it creates an action plan that clearly details the organizational roadmap. The reality is funders want to know about evaluation and sustainability. But again, this clearly sets the message so our collaborators, our partners in the community know exactly where we're going and what our intent is, but it also helps us to understand what the needs are from our collaborators and partners' viewpoint and what the needs are from our clients' viewpoint. Everyone is involved in the strategic plan. It helps us to identify and substantiate the need within our community, and then it allows us to focus our programming designed to specifically meet that need. We have a measurable impact, and we evaluate what's working in our program. We do a pre and post analysis on all of our clients that come in. We work with our collaborating partners, again, what's working, what's not working from their viewpoint, so that we can evolve and amend our program as needed. How did we change the community because of our program is a question that we always ask. We always want to make sure that the programs that we're facilitating tie directly back to our mission. Leadership and culture is critical to our success of our program. We want to have an effective and engaged board, and we want to get and keep the right people on the bus at the right time. So we focus on professional development, retention. We want to share expectations, and we have a succession plan that's ongoing and internal. It's written, current leadership is involved, and it has to be aligned with our strategic plan. This is my contact information. I went through a lot of information really quickly, but feel free to call me or email me with any additional questions that you may have.
Wendy, thank you for a comprehensive overview of the services and the operations at Dove House. What a wonderful overview. Thank you so much. A couple of questions for you. Dominique Levique asks, what is the current wait time for a bed at Dove House?
Unfortunately, we on average run about 4 to 5 months out. We average about 100 inquiries for our program. But part of our strategic plan is really looking at how do we continue to meet the needs of those individuals on our wait list. So we, have lots of ideas in mind and are actively working towards those to reduce the wait of time that a client has.
Thank you for continuing to build that capacity for much needed services. Amy McConnell asked a question along the same lines. She said, could you clarify please on whether or not pregnant women are accepted or women with newborns?
Pregnant women are accepted into our program. Unfortunately, the way our program is right now, we do not accept women with newborns, although that is a part of our strategic plan to look moving forward, how do we accept women with new babies?
Rate.
So when a client is in our program, we have a 0 recidivism rate. Clients are not rearrested while they're in the Dove House model. And a part of our STEP success, our recidivism rate was 0%. We did lose funding from that for a while. We just got that back and reinstated. But people that continue to participate in Dove House programming do not recidivate. Again, our goal is to really build out the Dove House model to ensure that we can continue to serve clients after they leave the Dove House model while they're on our wait list, and hopefully to expand residential beds.
What fantastic outcomes. A question regarding content and models. Does Dove House support any other pathway to recovery other than the 12 steps?
Well, I mean, we accept MAT. Everything is trauma-based here. We have 12-step meetings, but our program is not a faith-based model. It's a model of a higher power of their own understanding. We want to make sure that we don't exclude any person from our program based on their faith. So we're very clear that we are not a faith-based program. And because every client has an individualized treatment plan, they get to work with their peer case manager on whatever treatment modality works best for them. But we do have a couple of primary things. They have to meet with their peer case manager, they go to IOP, they participate in groups, and they have therapy. So hopefully that answers your question.
Yes, and Robin Peters actually provided additional clarification identifying specifically, do you use Smart Recovery or other secular programs?
We do not currently use those, but all of our objectives are SMART based, if that's what you're looking
Great, thank you. Thank you, Wendy. We have quite a few comments, one from Manda Beretta with Eskenazi Health, providing this. Thank you for building such a great program. We've worked with several women who have spoken highly of Dove House and felt very well supported there. So Manda, thank you for contributing that. And then quite a few questions on expansion plans. In the future, through Dove House, would you be looking at sobriety housing to create a Dove community?
We have lots of ideas. Obviously, funding is a challenge when it comes to capital, but it is part of our strategic plan. I would love to see houses that are secondary to our treatment program. I would love to see us expand our treatment program to serve more women. So it's just a matter of figuring out where those funds come from so that we can ensure that we're meeting the needs of women in the state of Indiana. We're not exclusive to Marion County only.
Wonderful. And expansion plans outside of the central Marion County communities, other areas of focus?
We don't currently have any areas of focus. We're not resistant to a community if they ask us to come there. My motto is, you give me the house and I'll figure out the rest. But the capital part is expensive. We've only been in the facility that we're in now. We went through an expansion 3 years ago where we went from a 23-person bed facility that was run down to a 10,000 square foot building where we house 40 women a night. We had to raise $1.6 million to renovate the facility, so it can be quite expensive. But it's certainly a part of our goals and part of our strategic plan that we're working actively towards. But no communities per se right now that we're looking at.
Thank you. And then pertaining to eligibility, what are the ages and or possible gender or sexual orientation eligibility for DOVE candidates?
So they have to be at least 18 years of age and female or identify as a female. Sexual orientation is not something that we don't have a sexual orientation clause in our policy. Any woman's accepted into our program.
Great, thank you. And a general question regarding funding. You had spoken a little bit about grants earlier. Could you again clarify how Dove Recovery House is funded?
Absolutely. So we have a pretty even mix of how our funding is broken down, about a 30-30-30 with some change. We get Medicaid and Recovery Works. We just became in network with Medicaid and began billing as a requirement through DMHA because we're level 4. We had to become a Medicaid provider. So about 30-some percentage of our budget comes from that. Another 30-some percent of our budget comes from individual gifts and fundraising. And then the rest come in the form of corporate of grants that we apply for. So local foundations and national foundations that we apply to.
Excellent, thank you so much. No, we're short on time today. There were 2 organizations that were reaching out to you, Wendy, to look at additional partnerships. And so we'll connect you with Victoria Hanley at Regional Health Systems, and also, oh, I'm sorry, there was just one partnership request. So we'll connect you and Victoria offline. Wendy, thank you so much for your presentation today and for all of the service and dedication support that you do for the women in recovery.
My pleasure. Thank you for having me.
Blake, back to you.
Thank you, Sunny. Again, Wendy, thank you for sharing the story of Dove House and its important work. This has been an excellent part of our symposium. We'll now turn to part 2, the Oxford House model, an evidence-based recovery housing model. Our presenter is Amy Collins. Amy is the Senior Outreach Coordinator for Oxford House of Indiana. Amy is a person in long-term recovery, celebrating 3 years this past August. She's opened 20 Oxford houses in both Kentucky and Indiana, while also working closely to develop homes in West Virginia and Ohio. Amy specializes in rural development, establishing 5 homes in Dearborn County and 6 homes in southern Indiana. Amy, we're looking forward to your presentation. The floor is yours.
Hi, good morning, everyone. My name is Amy Collins, and I am the Senior Outreach Coordinator for Oxford House for the state of Indiana. And today I'm going to talk to you guys about Oxford House and what it is that we do. Oxford House is a model for recovery homes. We are a peer-to-peer model with a tradition of clean and sober living spanning for over 40 years now. We are not a program. We are a single-family home with a set of recovery guidelines. Oxford House is recognized by SAMHSA as an evidence-based program and practices. Next slide, please. Oxford House began in Silver Springs, Maryland in 1975 with a group of men, including our current CEO, Paul Malloy. There was a group of men living together in a state-run halfway house, and this halfway house was closing. I am so sorry about that. This halfway house was closing, and you know, the men were doing so well, they decided that, you know, why don't we stay here and share the expenses and run this ourselves? And that's exactly what they did. One of the other men that was living in the house at the time, he is actually still works for Oxford House. He is a lawyer that works with us. That group of men shared the equal expenses of the home and continued to work a program of recovery. And they built a prudent reserve, and they saved enough money to open up another Oxford House. And that Oxford House is actually still open today. The first Oxford House, it closed back in the 90s. The owner passed away, and the family decided to sell. Otherwise, it would probably be still open today too. We currently have almost 3,000 houses across the United States to date. In the state of Indiana, we have 43 homes, and they are spread out throughout the state. We have South Bend and Indianapolis, Fort Wayne, Evansville, Bloomington, Southern Indiana, Dearborn County are the areas that we are in. So the houses have really there's no time span in which a person can live in the Oxford House. That you can stay there as long as you want, as long as you're working a program of recovery and you're paying your equal expenses, then you can stay as long as you'd like. One of the unique things about Oxford House is that when the need arises for another house, then we just open another house. There are some people that have been living in Oxford House for years. Like for me, for example, I lived in an Oxford House for almost 3 years before I moved out. And you move out when the time is right. And there's no rush, and we're always able to make room for more people because we just expand the model and we open new houses. Our houses are home to both men and women. We do not have co-ed homes. We have men's houses, we have women's houses. We also have women and children houses. And hopefully in the future, we will have men with children houses. That is something that we do, especially in Kentucky, where I come from. There was quite a few men with children houses, and you see that more and more men with custody of their children. Next slide, please. So each house must be democratically ran. And what that means is everybody who lives in the house has a vote. They vote on everything. They vote on who they allow to move into the house. They vote on what supplies they're going to buy for the house. They vote on everything. So everything is voted on and democratically run. And each member is responsible for paying a share of all the household expenses. Each house has its own individual bank account with 2 check signers. And they meet weekly to go over their bills, and they even vote on which bill is going to be paid that week. So the house must also immediately expel any member who returns to using drugs and alcohol. Those 3 things are the conditions, the charter conditions of how an Oxford house must be run in order to operate as an Oxford house. Next slide, please. So the members living in Oxford house must attend recovery meetings. They must participate in a program of recovery. And we don't dictate of what type of meetings that they attend. We support all pathways to recovery. It could be whatever recovery works best for them. A lot of our residents use Alcoholics Anonymous and Narcotics Anonymous. Some use Smart Recovery. In Dearborn County, it's really common for them to use a CBT-based recovery program called Challenge to Change, and it works really great in that area. And we are supportive of whatever works for them. Individuals must detox before coming to Oxford House. We are not a program, we're not a detox facility, so we are not equipped with members coming in who are detoxing. So that is a part of the interview process. Those types of questions are in the interview. And although it is a recommended 30 days of sobriety in order to move into an Oxford house, it is not a requirement. And increasingly, we see people with maybe 14 days clean and sober, and it's not a deal breaker. It just means it may be a little bit more challenging to get 80% of the vote. But it is something that you technically just need to have detoxed off of drugs or alcohol. In a lot of cases, people detox in jail. That is a lot of people's story, and 75% of Oxford House population across the country is reentry, and reentry residents seem to do really well. And I feel like it's maybe because they've been perhaps separated from the drugs and alcohol long enough to have a clear mind. And then once in an Oxford house and you are with a group of like-minded people who are just trying to do the next right thing, it just seems to fit. It seems to work. Next slide, please. So Oxford House has 9 traditions for success, and those traditions are principles by which the residents must live by. Like I said before, each house is democratically self-run, and the house membership is responsible for all household expenses. The House must immediately expel any member who uses alcohol or drugs. And the reason for that is because it is harmful and dangerous for other members. If a person continues to live there without, you know, a person can come back after 30 days, but they must return to sound sobriety, is actually what our manual says, that a member must return to sound sobriety, and then they can come back to Oxford House. Next slide, please. So how to get into an Oxford House. You can go to our website, which is oxfordhouse.org, or you can go to our vacancy website, which is oxfordvacancies.com. And I am a big fan of our vacancy website because it's super helpful and simple to use. You just oxfordhousevacancies.com. It has a prompt for which states that we're in, and you just simply put in the state, the gender, and what county, or you can just click all, and all of the counties will come up. It even shows you the address of each particular house. It will tell you the vacancies of that particular house and a point of contact for that house. Super simple. So next slide, please. Like I said, you could just put in what city that you want to go to, whether it to be women and children, show only houses with vacancies. Our website is pretty easy to use. So you just click on that and find the phone number for that particular house, and you call them to set up the interview. Next slide, please. So you call a house to set up an interview, show up on time for an interview. The interview questions are just a series of recovery related questions. Just the residents want to get a feel of where you're at in your recovery, and you know, I think it's a list of like 15 questions, and each member usually has their own particular question that they'll ask you with. And honesty will get you pretty far. I've seen that to be true. And every other vote that takes place in the House, majority plus one always wins. With accepting a new member in a House, it must be 80% of the vote. If accepted, a new member may move in immediately. There are costs. We are, not a program, so we do not accept any type of insurance or anything like that. Members must get a job within 2 weeks of moving into the House. And it is $100 move-in fee, and on average is about $125 a week to live in the house. It just varies by the house and how many people's living in the house, and so that weekly amount varies. And it also, the weekly, we call it EES, equal expenses shared. So that EES includes a person's toiletries, their laundry detergent, toilet paper, any household items, coffee, creamer, anything of that nature will be included in that weekly amount that they must pay. Everything is provided except for their food and toiletries. Next slide, please. Where are the Oxford houses located? We are located in nice homes in nice neighborhoods. We take pride in that. I remembered whenever I moved into my first Oxford house, and it was the nicest house that I had ever lived in. And it was so exciting to come from a treatment facility to that. And I think that that was one of the reasons why we took such great care of it, because it was ours. It was something that we took pride in. And there is a weekly chore list that the members go over in their weekly house meeting. And that keeps up with the day-to-day maintenance of taking care of the house and doing chores, and also teaches responsibility. So Oxford houses are situated in prosperous, friendly neighborhoods throughout the nation. We are located in 48 states and 5 countries, which include Australia, Canada, Ghana, and the United Kingdom. Next slide, please. So another thing that makes Oxford House unique is the investment that members place in these homes. So the houses are run by trusted servants, which is elected officers, and it consists of a president, a treasurer, secretary, comptroller, and chore coordinator. And each role is very important. The president is in charge of the weekly house meeting, making sure that it is run smoothly and that they don't get off track. There is a meeting format that they follow each month. Each week. They go off of that meeting format. The treasurer is a pretty important job as well, and they are in charge of keeping track of the household expenses. Each position, they have a binder and they keep record of everything. Oxford House meeting minutes are very well put together, and they are actually admissible in court. Like, that's how well they're put together. The treasurer, like I said, will keep track of all of the bills and write down how much money they're taking in weekly, and how much money's coming in, how much money's going out, what was paid, the check number, and things of that nature. Secretary, they will take the meeting minutes. They will take notes of everything that takes place in the meeting. The comptroller is the person who keeps account of the weekly EES that's paid to the house. It is due every week on Saturday by midnight. So Sunday morning, they will go in, they will take the money orders, and they will put it in their books, and that's what that looks like. And the chore coordinator is pretty self-explanatory. They're the person who provides the chore list weekly. And it is up to each house to, it's up to each person to make sure that they do their job properly, and so the house runs smoothly. Next slide, please. Future expansion in Indiana. we will continue to expand in Indiana. New Oxford houses will be opening beginning October 1st. We will open 21 more houses across the state. Currently, we have 43 opened and operating under the Oxford House model. All regions will be covered statewide. Currently, we have 5 outreach staff across the state. Beginning October 1st, we have 2 more that's going to be joining our team. We're really excited about that. Cities that we're actively looking to expand are Hammond, Scottsburg, and Terre Haute. Expansion will include these and other rural areas. Since COVID hit, we've really just kind of put expansion on new areas on hold until we can actively network those areas, and hopefully as things start to get a little bit back to normal, we'll be able to expand the way that we are hoping to. And right now, I believe I mentioned it, the cities we currently are in, it include Indianapolis, Fort Wayne, Evansville, South Bend, Bloomington, Lafayette, Clarksville, New Albany, Jeffersonville, Columbus, and Dearborn County. Next slide, please. So Oxford House is a solution. State investment to fund Oxford House expenses contributes to making people productive citizens, reduces homelessness, and prevents relapse. There is we are evidence-based, and there have been several studies done on Oxford House since 2006, and it is shown that if you stay in a house for over 12 months, that you're 90% less likely to relapse. The life skills that Oxford House gives you, it gives you the opportunity to be a productive member of society, and to learning how to pay your bills, and learning how to treat others with respect. And it's a really great model, and it saves taxpayers money. These homes are they're paid for by the members living in the house. They are self-run, self-supporting homes, and that's another one of the really cool thing about Oxford House is saving the state money by paving its own way, so to speak. As we reduce the number of relapses, the cost of incarceration and homelessness drops. The success of long-term recovery is possible. Like I mentioned, Oxford House has a 90% success rate after 12 months. The number of alcohol, drug-related crimes like physical abuse drops. Next slide, please. That is the last slide. Thank you, guys.
Amy, thank you for sharing such wonderful information about the housing's impact for recovery and resiliency. Oxford House is certainly an incredible network of opportunities for individuals to find not only housing, but that collaboration towards their long-term recovery. We've had a significant number of questions coming in, and so I'll attempt to consolidate those. A couple questions regarding the programming. Earlier, you had mentioned that individuals are essentially peer monitoring whether or not folks are using drugs. How does that extend to those that are participating in medication-assisted treatments?
I'm sorry, could you repeat the question?
Yes, does Dove House allow for people to live in home while participating in medication-assisted treatment?
I'm sorry, did you say Dove House?
I'm so sorry. Does Oxford House allow for individuals participating in medication-assisted treatment to live in-house?
Absolutely, yes. We support all pathways to recovery. The person who's on the medication must keep their medication locked up. There is an extra level of accountability where the medication must be counted in front of their peers at their weekly house meeting.
It's great. There's so much collaboration and accountability. A couple questions regarding how that collaboration works together. At Oxford House, do you have a grievance process, and what does that look like?
Can you explain that?
Yes, there's such a great amount of peer-run decisions and folks working together within the home. What happens when, let's say, a particular unit doesn't get along? Is there a grievance process? Is there anyone that
No,
you
we have
to?
a lot of like contracts, behavior contracts, financial contracts. I mean, it's just a part of life that some people are not going to get along. That's going to happen, especially when you have, you know, 7, 8 people in early recovery living in a house together. And they work their differences out. That is just something that they're forced to do if they want to live in the house. But it also gives them an opportunity to learn how to work well with others, which is something that is hard for people like myself and people in recovery to do when coming into recovery.
Absolutely. There was a discussion earlier about the current individuals living in the house having the decision making on new applicants. Is there a contract towards anti-discrimination? Is there a contract towards or training pertaining to cultural competency to account for open arms for applicants of all races, gender, sexual orientations, etc.?
Right. So we do train them, like the outreach staff trains them on cultural competency, and we pass along the things that we learn. I haven't experienced that. I mean, these are autonomous houses that are peer run. So I haven't experienced anyone having any type of discrimination known that I am aware of.
Thank you. Could you share a little bit about outreach staff and how they are, their availability and the best way to contact them?
Yes. So let me think about that. If you go to the website, I believe my phone number is listed on the website. Don't think that the rest of the staff's phone number is. However, if you get in contact with me, I can pass their information along.
Great, thank you so much, Amy. And I've shared the title slide with everyone again where your contact information is listed. Is that the correct number?
No, this is the main office in Silver Springs, Maryland. But if you go to that website, my information is on the website.
And could you share the web address with everyone as well? Again, the oxfordhouse.org?
Yeah, it's at the bottom of the
Okay.
screen here, www.oxfordhouse.org. And if you're looking for a vacancy, you can also go to oxfordvacancies.com.
Great. As far as expansion, is there a plan to have an Oxford House in every county in the state?
It would be nice. I would love that, but every county, I'm not really sure, because we have to set people up for success. And some of the requirements to live in Oxford House is to go to recovery meetings, and there's just not recovery meetings in every county, like the number that is required of them to attend. Those are some of the things that we take into consideration when we're going to a new area and trying to see if it would be a good fit. We have to look at things such as employment and recovery meetings. We like areas that has public transportation. It's not a deal breaker, but public transportation is nice for because most people in early recovery do not have vehicles, and it's very helpful for them. It's a barrier that is a barrier broken with public transportation.
And some really key as far as social determinants of health, absolutely. There are some partner requests on the question pane, and one of them is Overdose Lifeline with Jude Brown, the AmeriCorps member working with Overdose Lifeline. And Jude would love to reach out to Oxford House about supplying naloxone. And so we'll connect you both after this session. And then, are there any other evidence-based model research or quality metrics that you could share with the attendees as a follow-up?
I'm sorry, can you repeat the question?
Yes, could you share some additional research on this evidence-based practice with our attendees as a follow-up?
Yes, I can.
Wonderful. If you could send that to me, that would be great.
Okay.
For the attendees, we have a few minutes left, so please do type in your questions for Amy at the Oxford House into your question pane. See a few folks typing away here, so we'll just give them a few minutes, or rather a few seconds. Another question regarding the current COVID-19. Are we still doing at Oxford House active intake and applications and vacancy updates during this time?
We have been, yes, we have actually accepted people through this whole ordeal. They've just had some added questions on their interview process, like, have you been sick, shortness of breath, those sorts of things. And, so far so good. We haven't had any positive cases. So yes.
Great. Some policy and neighborhood marketing questions. Have you ran into any not in my backyard, really just unsupportive commentary or feedback? And what have you found to be a good pushback towards that kind of negative reaction?
Well, honestly, Oxford House just speaks for itself. Like, when we first come to South Bend, we got a lot of pushback, and we're starting to see that in Columbus as well. We're getting ready we just opened our second house like this past weekend in Columbus, and we're starting to see that. But what we have seen in South Bend is that if we just kind of don't feed into it and they see how we operate and that we're actually really good neighbors, and we take care of our yards, and we don't, it's not a, we've even actually went and introduced ourselves, and they don't expect that. They don't expect that we are people just like them, and that the stigma attached with people in recovery is not always, it doesn't always match up like with their perception and the reality of it. Like I said, a lot of the times if you just leave it alone, and they over time see that they're pretty good neighbors, they kind of back off.
I think that's wonderful. I think for those that have never had an experience with persons in recovery or this wonderful Oxford House model, that it really is ensuring that there is that social effort and having that interaction to see that this really is a place for neighbors. So thank you for all of your work. One last comment and one last question. We thank David Mankin for sharing his own testimonial. David shares that he started out his recovery in sober living and is really glad to see that more help is available. So thank you to you, Amy, and Oxford House for continuing to grow the total number of available homes for those in recovery. Joyce Fillenworth has a comment regarding really kind of the categorization of Oxford House. With more freedom in Oxford's model than in a traditional recovery house, has Oxford thought of maybe marketing more as a next step from recovery houses versus a next step from a treatment center?
No, and the reason is because if you understood the level of accountability in an Oxford House, I think it would be more self-explanatory of why we would not do that.
Well, Amy, you certainly have gone through comprehensive processes and operations with us today. Thank you so much for sharing and for leading the growth on a much needed community resource in support of persons in recovery. We appreciate your presentation and the information shared. Please do send additional follow-ups so that we can share with the attendees. And thank you so much.
Thank you.
Thank you.
We're now going to turn it back to Blake for an overview on the next session.
Thank you very much, Sunny. And also, again, Amy, thank you for telling us about the important work being undertaken every day by Oxford House. I think that everyone online today will agree that this has been another excellent part of the INARMS Symposium for 2020. Bearing that in mind, I'll remind everyone to please join us for today's keynote, which is next on our agenda and will start at 11:45 Eastern Time. Remember to use your join link to log on to the keynote. We're looking forward to having you join us. Enjoy the rest of your morning.